Hello, everybody. I hope everyone is doing well today. Thank you for inviting me to participate in your CME. I am very honored to be here today. My name is Farouk Dako. I am an assistant professor of radiology, specifically a cardiothoracic radiologist at the University of Pennsylvania. And today I'll be talking about imaging of COVID-19 in adults. So a little background. We know that the SARS-CoV-2 virus is spread primarily via respiratory droplets during close face-to-face contact. The average time from exposure to symptom onset is usually 5 days, and most people, almost 100% of people who develop symptoms do it within 5 days to 11.5 days. And the most common symptoms we see, fever, dry cough, and shortness of breath. We know the SARS-CoV-2 virus is diagnosed via reverse transcription polymerase chain reaction testing. And throughout the pandemic, false negative results have been reported in 20% to up to 67% of patients based on technique. And we know this was the case more early on in the pandemic when tests were earlier in their development phases. So just a little background, epi, as to how everything unfolded. A cluster of pneumonia cases of unknown cause was reported in the city of Wuhan, China, by health officials on December 31st, 2019. And during the first 3 weeks of the outbreak, cases were reported from only 2 countries outside of mainland China. However, during weeks 9 to 11, the proportion of countries and locations with confirmed cases of COVID-19 increased from 32% to about 50% of countries in the world. And the first cases in Africa were reported during this time, from about 9 weeks after the start of the pandemic in Algeria. So this just shows you some of the early events in the COVID-19 pandemic. As you can see, Africa only contributed a small proportion of cases, especially early on. And most of these cases in Africa specifically were as a result of travel to Italy and travel to other countries, and less actually directly from travel to China. Scrap over here just shows you again that just weeks after the pandemic, it took a while for Africa to be involved, and when it was a relatively small contribution compared to the rest of the world. So as of March 2020, 4 months in, 99% of countries, almost half of the countries in the world and locations outside of China have reported cases of COVID-19, of which 76% identified their first reported cases in an individual with history of travel to an affected country. 22% would travel to China, 11% to Iran, 27% to Italy, and 15% to a different country. So just talking about pathophysiology a bit before we dive into imaging. The SARS-CoV-2 virus is a large enveloped single-stranded RSNA virus found in humans and other mammals. They have distinct spikes and they cause respiratory, gastrointestinal, neurological disease, as well as cardiovascular disease. So they target cells, host cells, through the viral structural spike, so-called S protein here. And that binds to an angiotensin converting enzyme 2 receptor in the host cell here. And the type 2 transmembrane serine protease in the host cell promotes viral uptake by cleaving the ACE2 and activating the S protein, which mediates coronavirus entry into host cells. We know that nasal and bronchial epithelial cells and nematocytes express a high level of ACE and TMPRSS2 receptors. And we know ACE is also highly expressed in the epithelial cells of the oral mucosa and lungs, but also heart, blood vessels, intestines, kidneys, bladder, and brain. And this helps to explain some of the distribution of pathology that we see. So here, as we see, the SARS-CoV-2 virus gets into the cell, the host cell, via endocytosis, releases its RNA, and uses the cell machinery to replicate itself and assemble more variants. And then it leaves the cells and affects other cells. So what do we see early on in this disease? We can see profound lymphopenia, which occurs when SARS-2 infects and kills T lymphocyte cells. And then we get an inflammatory immune response, right? Which is able to impair lymphopoiesis and increases lymphocyte apoptosis. So the diagram over here shows COVID within a type 2 pneumocyte, right, which, as we know, lines cells within the lungs. It infects it, it replicates, it releases it, it incites an inflammatory immune response, cytokines are released, right, and they are brought in to that region. As disease progresses, the epithelial endothelial barrier is compromised, the integrity of the barrier is compromised. We see an endotheliitis. So this is, in the lungs, you have the epithelium lining the alveolar space, and you have the endothelium where the capillaries are found, right? So as the virus makes its way through the compromised barrier, it infects the endothelium as well, right? So there's a vascular involvement. And with the compromised barrier, just like with ARDS, you have pulmonary edema, you have pulmonary edema filling the alveolar spaces, and you have hyaline membrane formation. Okay, so similar to the early part of the acute phase of ARDS. And then in severe cases, you'll have activation of coagulation and consumption of clotting factors, right? This results in pulmonary thrombus formation that we see, right? And as it progresses, you can have a diffuse intravascular coagulation, the so-called DIC. This could result in viral sepsis and widespread infection. So just to highlight the role of pulmonary vascular endotheliitis, thrombosis, and angiogenesis in COVID-19 pneumonia. This is a paper by the New England Journal of Medicine that did a small series that showed that vascular angiogenesis is what distinguished pulmonary pathobiology of COVID-19 from that of equally severe influenza virus infection. So influenza virus infection was shown to cause endotheliitis and involve the capillaries as well and the endothelium. But what was really unique about COVID-19 was this vascular angiogenesis that was seen in this small series of about 20-something patients on autopsy. But what we've seen in radiology is that we're able to demonstrate this extensive vascular abnormalities. So this is a CT pulmonary angio done with dual energy. This is the iodine maps. I personally like dual energy a lot for various reasons. But specifically, you can show this regional segmented, dilated, segmented, and subsegmental pulmonary vessels, right? So in the affected areas with ground glass opacity, you're able to see these dilated vessels, right, compared to the non-affected areas. And on the iodine maps, you're seeing this area of higher iodine perfusion or iodine concentration compared to the non-affected area. So this is us showing this extensive vascular abnormalities that that folks were seeing on autopsies. We're able to show it on patients by one, looking at the tortuosity and dilatation of the segmental and subsegmental arteries. And on the perfusion maps, we're seeing this abnormal perfusion, right? In this patient, as you can see, there's some consolidation more posteriorly, which correlates to an area of decreased perfusion. So it seems like early on in the disease, there might be some increased perfusion, but then as it progresses to consolidation, there's probably a decreased perfusion. So early on, as we started to compile cases, predominantly from China, people started to describe the hallmark CT features of COVID-19. And they include on chest CT, bilateral and peripheral ground glass opacities, consolidated pulmonary opacities with or without septal lines. Sometimes they have a rounded morphology and this vascular engorgement, like I showed you. Initially, people were reporting just a focal area of vascular engorgement, but like I showed you in the previous slide, and this separate paper, which is also in the New England Journal of Medicine, some researchers from Boston showed that there's a more extensive regional area of vascular abnormalities. So yeah, so these were the early described hallmark CT features of COVID-19. In addition to this, the opacities were usually lower lung predominant and more posterior, right? So bilateral, peripheral ground glass opacities, usually with a lower lung predominance, usually more posterior than anterior. And the typical features that were not present were pleural effusions, lymphadenopathy, pulmonary nodules, and lung cavitation. So these are atypical features of COVID-19. So based on this, actually, this study was led by one of my colleagues, Scott Simpson, who actually provided a lot of the images for this talk. This was documented by the RSNA in the US, also endorsed by the STR and ACR, that came up with a suggested reporting language, right? So a way to approach reporting out COVID-19, which a few institutions have definitely adopted. This is not the only one out there. I know there was one from Europe called CORAD, which is another way to be able to structure your reports, which helps with data mining, right? If you want to be able to pull up the cases through a search engine. So let's just go over this real quick. So typical features, right? So these are commonly reported imaging features of greater specificity for COVID-19 pneumonia. Peripheral, bilateral, multilobar, so involving multiple lobes, ground glass opacities with or without consolidation, or visible interlobular septal lines. So-called crazy paving, when you have ground glass and interlobular septal thickening. Multifocal ground glass opacities of rounded morphology, with or without consolidation, or visible interlobular septal lines. Reverse halo sign or other findings of organized pneumonia, which is usually seen more later in the disease. Indeterminate features, so non-specific imaging features of COVID-19. absence of typical features like we just talked about, and multifocal, diffuse, perihilar, or unilateral ground glass opacity, with or without consolidation, lacking a specific distribution, and are non-rounded or non-peripheral. A few ground glass opacities with a non-rounded or non-peripheral distribution. And a suggested way to say it is imaging features can be seen with COVID-19 pneumonia, though are not specific and can occur with a variety of infections, infectious and non-infectious processes. And we have atypical, which we talked about. So these features are uncommonly or not reported features of COVID-19 pneumonia. So absence of typical or indeterminate features and presence of isolated lobar or segmental consolidation, right? So you have this focal area of infection, because we know COVID it's not one that affects a focal area of the lungs, rather a diffuse, it's a diffuse process. So discrete small nodules, centrilobular or tree and bud nodules, lung cavitation, smooth interlobular septal thickening with pleural effusions or atypical findings, right? You want to think more, pulmonary edema, cardiogenic or non-cardiogenic, things like pneumonitis, and things of that nature. And then negative, right? So you read a chest CT and you see no opacities, it's okay to say no CT findings present to indicate pneumonia. Because remember, CT can be negative in early stages of COVID-19, right? So it's specific to pneumonia, COVID-19 pneumonia. So let's look at a few cases, this from my colleague, Scott Simpson, showing peripheral, right, rounded morphology, right, as you can see. And they have these like intralobular septal lines when you really zoom in. Again, you have these ground glass opacities. You have some of them with these rounded morphologies, peripheral, right, or more typical findings of COVID-19. And again, rounded morphology, right, as you zoom in. From my colleague Scott Simpson. These are cases from Michael Chung in New York, showing this peripheral ground glass opacities, right? So these are not rounded per se, but they're peripheral ground glass opacities. There are probably some intralobular septal lines associated with it. Again, peripheral consolidative and ground glass opacities, right? So these are more typical features of COVID-19, sort of sparing the more central lungs. Remember, these features are still there's still other things that can cause peripheral consolidated opacities, like in this case of organizing pneumonia, right? So obviously prevalence of the disease is important. You need to know the epidemiology of COVID in your region. So the case of influenza pneumonia also showing some peripheral ground glass opacities. Okay, so as we go on, these are more indeterminate features, right? You see ground glass opacities with some sparing of the most peripheral lungs, right? You have ground glass opacities, non-rounded, sort of extending this way. These are all COVID-19 cases, which are indeterminate imaging features. Okay, again, ground glass opacities, sort of peripheral as well as like centrally. It's all important to remember other causes of ground glass opacity when you report in COVID cases. So it's the cases of drug toxicity, right? You see some ground glass opacities, again, more extensive drug toxicities. These cases could represent COVID-19 pneumonia. So the history is important, okay? Pneumocystis pneumonia, we still see that a lot with immunocompromised patients, right? Again, ground glass opacities, not typical for COVID-19 pneumonia. They're indeterminate. They could be seen with COVID-19 pneumonia as well. So thinking about some atypical features, right? So this is a patient with COVID positive, but more focal area of consolidation. So this should make you think of coexistent infection, right? In addition to the COVID-19 pneumonia. Another case here. So extensive consolidation, as you can see when you zoom in here, you see a cavitary lesion, right? This is not a typical finding of COVID-19 pneumonia. Patient to the right, non-tuberculous mycobacterial infection with thromboembolism opacities, right? And some cavitation. These are not typical findings, atypical findings of COVID-19 pneumonia that should make you think of other things. Remember, most other viral infections in the lungs cause ground-glass opacities. In this case, RSV has some nodules here, should make you think less of COVID, as well as here, this peribronchial nodular ground-glass and consolidated opacities, should make you think less of COVID. Okay, so that's just a quick review of imaging findings of COVID-19 pneumonia. And again, we're going to talk about this more, but remember, you're looking for peripheral predominant opacities, typically lower lung predominant, typically in CT, more posterior than anterior. You can have rounded morphology, and you shouldn't really have cavitations, micronodules, tree and bud opacities. You typically don't have a lot of like pleural effusions, and you shouldn't expect things like lymphadenopathy as much. Okay, so a lot of the data that came out early on during COVID was from China due to the increased prevalence. So this really, a lot of folks that were using chest CTs for COVID-19 due to the fact that PCR tests were not as available at the time. So there were a lot of studies because there were a lot of patients being scanned with chest CT. So in a series of 51 patients with chest CT and PCR performed within 3 days, they showed that the sensitivity of CT for COVID-19 infection was 98%, compared to the PCR sensitivity of 71%. So this data really drove a lot of push to use CT scans in patients with COVID. But like I said, remember the prevalence was very high, and the PCR tests were not as good at the time. So like I said, their results support the use of chest CT for screening for COVID-19 for patients with clinical and epidemiologic features compatible with COVID-19 infection, particularly when PCR test is negative. So again, this study and a few others really drove this pattern that we actually started to see in the US, where patients came in, they were suspected to have COVID, and some got a chest CT because the PCR tests were taking very long to come back, and clinical decisions were made on that. And even when the PCR tests were negative, people still got chest CTs, and if they were positive for typical findings or any findings that supported COVID, they were treated as such. Another paper that came out early on as well from China showed that with PCR as reference, the sensitivity for chest CT imaging of COVID was 97%. Okay. In patients with negative PCR results with positive chest CT, almost half of them were reconsidered as highly likely cases, with 33% of them as probable cases based on a comprehensive evaluation. So there was really a push to use chest CTs for screening patients suspected with COVID based on the early data that we were getting from China. So things started to change a bit as more studies were done. This is a study from a cruise ship. You might have remembered there were a lot of cases on these cruise ships early on in the disease in the course of this pandemic, because people were stuck in these ships for a while actually, and were looking for a place to be let out. So in this case, they reviewed CT scans from 112 cases of PCR confirmed COVID-19 from the Diamond Princess cruise ship. Well, interestingly, they found that less than 2/3, okay, of cases had lung opacities on CT. So known PCR cases, only less than 2/3 had opacities on CT. Okay, and 20% of symptomatic patients had negative CTs. They also found that lung parenchymal changes on CT in up to 54%. So a little over half of asymptomatic cases had lung parenchymal changes on CT. So I think this study was one of the studies that started to change sort of the narrative of the role of CT and COVID-19. So this and other studies showed this similar sort of data, that more than half of patients imaged quickly after symptom onset had a normal scan, right? So early days 0 to 2, right? Normal chest CT was basically seen, and more than half of the people imaged in early days from symptom onset, okay? And as symptoms progressed, you had more consolidation, right? And bilateral disease and peripheral distribution. And then as time went on, you had more linear opacities, which we're going to talk about a bit. So what about chest x-rays? So as a screening modality, people looked into this as well. And it was found that in a cohort of patients with COVID-19 infection and imaging follow-up, baseline chest x-ray had a sensitivity of 69% compared to 91% for initial PCR. Chest x-ray abnormalities preceded positive PCR in only 9% of cases, okay? So this did not support chest x-ray as a screening modality for COVID, okay? When chest x-rays are positive, the common findings basically mirror what we talked about on chest CT, which is you have bilateral, peripheral, lower lung predominant opacities, right? You can't really tell the difference between consolidation and ground glass and chest x-ray. All you really can see is opacities. They could be hazy, they could be more dense, but they should be typically bilateral and peripheral. So based on their early data, the Fleischner Society, which is a multinational group of thoracic experts around the world, came out with a statement that imaging is not indicated in patients with suspected COVID-19 and mild clinical features, unless they are at risk for disease progression, right? So they have mild clinical features, but the clinician thinks they could be progressing. You can start with a chest x-ray to see if they actually have a pneumonia, and CT scan could be used if there's suspicion for other things. They also said imaging is indicated in a patient with COVID-19 and worsening respiratory symptoms, right? So if they have worsening symptoms and you think they might have a pneumonia, and you can start with a chest x-ray, and typically we, at least in the few institutions I've worked in over the last few years, try to limit it to chest x-rays. However, some institutions use more chest CTs. I mean, it really depended on the pulmonary doctors and practice patterns and what paper people read recently, I guess. So the time course of CT changes, is important to know. So like we said, if you scan very early in the disease, you could find nothing. But the most common initial findings in chest CT scans were small subpleural ground glass opacities that grew larger with crazy pavement pattern and consolidation. Lung involvement increased to consolidation up to 2 weeks after symptom of onset. And this makes sense, right? Because we know a lot of times ground glass opacity is due to infiltration of the septum, the secondary pulmonary lobule has a septum that surrounds it, and people call that the interstitium, right? So sort of like an interstitial edema kind of thing, right? But as you infiltrate into the alveolar spaces, so like we talked about, when you have loss of integrity of the endothelial and epithelial barrier, you flood fluid and hyaline membrane into the alveolar spaces, and this typically results in more consolidation. So this takes some time. And then after 2 weeks, the lesions were gradually absorbed, leaving some ground glass opacities again, some of which represent fibrosis, some scarring, and some subpleural parenchymal bands. So in one study, about 94% of patients discharged had residual disease in final CT scan. So, you know, when you see some disease, some opacities on CT scan, it's important to understand the clinical picture, right? So it doesn't always mean that the patient is having active disease. It could be a resolution from disease. So this just shows you just just showing you some progression, starting off with really ground glass opacities and some consolidated opacities. And a few days out, I believe this is 3 days and 7 days, you have more extensive ground glass, some crazy paving, some more consolidation. Okay, and then 11 days, as things were getting better, right? You have some more band-like ground glass, some new area of consolidation. And then by about 20 days, as you can see, there's just some faint ground glass and some band-like opacity. So probably some residual scarring at the time. So again, this just shows you really the timeline of CT changes, as we said, right? So stage 1, early on in the disease, you have more ground glass opacity, right? And then as time progresses, this is about 2 weeks, like we said, you have a lot of consolidation, right? And in between that, you have the crazy paving pattern. So some interlobular septal thickening associated with the ground glass and consolidation. So this just shows you, again, just trying to correlate CT scores, opacities with time from onset of initial symptom. So a study that came out not too long ago, recently, just showed patients with 6-month follow-up chest CT findings after severe COVID-19 pneumonia. And it showed that 6 months follow-up chest CT basically demonstrated fibrotic-like changes in the lungs in more than 1/3 of patients who survived severe coronary disease, COVID-19 pneumonia, right? So as you start to image patients further out, we're now starting to see basically patients that have organized pneumonia, which is progressing to fibrosis. So these are just some images that show you some of the more long-term sequelae that we're seeing in COVID-19 patients now that we have to be on the lookout for. So, people have all sort of names for it, post-COVID syndrome, long haulers, but as thoracic radiologists and pulmonologists, it's important to know that a lot of these patients are having some residual loss of pulmonary function due to residual fibrosis. And in this study, the changes were associated with an older age, having ARDS, acute respiratory distress syndrome, longer hospital stays, tachycardia, who had non-invasive mechanical ventilation, and who had a higher initial chest CT score. So they came up with chest CT scores based on the extent of the involvement of the lungs. So is there a correlation of CT findings and clinical severity? Some people think, yes. When you start to see interlobular septal thickening, air bronchograms, pleural effusions, like we said, like those are rare. But when you have things like that, in addition to pure consolidation, which were more prevalent in the severe clinical form. As you can imagine, pure ground glass opacities mainly manifested in patients with a mild form. So you see pure ground glass in a mild early form of COVID-19 before you have that disruption of the endothelial epithelial membrane and flooding of stuff into the alveolar space. So some people showed that you could have what you call a chest X-ray severity score. So this is actually done by some of my colleagues as well in New York. They basically segmented the chest into these different segments and calculated how many of these segments were involved by opacities. And they showed that, after adjusting for demographics and comorbidities, a chest X-ray severity score of greater than 2 was associated with hospital admission, odds ratio of 6. The patients who were admitted, a chest X-ray score of greater than 3 was an independent predictor of intubation. So, this study just showed that, you can sort of prognosticate a bit with based on extent of opacities in chest X-ray. Now, we mentioned early on about vascular angiogenesis and the vascular involvement of COVID, but we started to see early in the disease that there's this prothrombotic syndrome, right? People were showing up with like large vessel strokes and things of that nature that made folks realize that thrombotic complications are important sequelae and contribute to significant mortality and morbidity. Okay, so PEs, DVTs, ischemic strokes, bowel ischemia, MIs were all then seen in patients with COVID-19. One study showed that the incidence of PE or pulmonary thromboembolism, because my suspicion is that not all these filling defects are actually from pulmonary emboli. Some are from in situ thrombosis, right? Given everything that we've talked about, although it's hard to tell the difference. I believe that a lot of the filling defects we see in COVID-19 patients are due to in situ thrombosis. And they've been reported in almost a third of patients with COVID in some series. There's mixed reports about the prognosis of PE, right? Because it's part of the pathophysiology of COVID-19. However, a strong correlation between elevated D dimers and poor prognosis has been found. And like I mentioned earlier on, studies have found a microvascular injury and thrombosis as a pathophysiologic mechanism. So switching gears a bit, let's talk about the heart. So cardiac involvement in this study from JAMA Cardiology was seen in almost 80% of patients with recent COVID-19 illness. And ongoing myocardial inflammation was seen in 60% of these patients. So it was 100% patients total. So 60 of them, which is 60%, showed myocardial inflammation with recent COVID-19 illness. Independent of pre-existing conditions, severity, overall course of acute illness, and the time from original diagnosis. So they found even patients who were discharged a week versus 2 weeks later all had this cardiac involvement, which is kind of scary, right? Because they're saying, regardless of severity of your disease, you could have cardiac inflammation. And out of all the cardiac parameters, native T1 and T2 were the best measures that were used to discriminate COVID-19 related myocardial pathology. They also found things like scarring and pericardial inflammation, but really native T1 and T2 markers were the best measures. What about abdominal findings? So this ACE2 receptor is also seen in the lungs, but small bowel and vasculature, suggesting abdominal viscera may be susceptible to injury. And in fact, a study showed that up to a third of inpatients with COVID-19 had abdominal imaging, and 17% had cross-sectional imaging based on symptoms. And imaging was associated with age. So older patients were more likely to get imaging and intensive care unit admission, right? So 31% of CTs showed bowel abnormalities, And late signs of ischemia were seen in 20% of CTs in ICU patients, with pathologic correlation suggesting small vessel thrombosis. 54% of right upper quadrant ultrasounds demonstrated findings of cholestasis. Okay, so, abdominal findings should not be ignored in patients who present possible COVID-19 infection. So this just shows some sequelae of ischemia, some mural thickening, bowel or edema surrounding fluid, and mesenteric engorgement. Neurologic findings have also been reported. Like I said, large vessel strokes have been reported, infarcts, hemorrhage, acute hemorrhagic necrotizing encephalopathy. Okay, which is this. I'm not a neuroradiologist, but this I found interesting as a potential sequela of COVID. People found these juxtacortical and callosal microhemorrhages, right? These are susceptibility images. It's showing you some of these dark areas of represented microhemorrhages. Other findings that have been reported is diffuse leukoencephalopathy, right? So you have these areas of high intensity on T2 weighted images, right? Flare that show you involvement of the white matter. So coming to an end here, this is a study that I was involved in, published in Radiology. We just looked at CT scans obtained for non-pulmonary indications. So patients came into the ED during the first wave of COVID, and we found that the presence of pneumonia in the visualized lung bases, like a CT abdomen, on a non-chest CT scan, in 64% of patients led to a COVID-19 diagnosis in 37% of patients. So even when you're reading CT abdomens, make sure you're looking at the lung bases, right? Because we said COVID-19 findings are basal predominant. And you can pick up findings and suggest the possibility of COVID-19 pneumonia, okay? And overall, patients diagnosed with COVID-19 presented with primary non-respiratory symptoms often had poor outcomes, right? So like we said, when this virus gets more systemic, it affects the rest of the body, and you can imagine that these patients usually have more viral sepsis. So in our particular study, they poor outcomes, they developed severe symptoms requiring major intervention, and up to 20% of people died. This is just a study from our cases from our study showing CT abdomen, but catching some peripheral ground-glass opacities here. And here was a CT neck catching some peripheral posterior ground-glass opacities that triggered a COVID-19 test. That was early in the pandemic. Now everyone gets a COVID-19 test when they come into the hospital. So just closing with this, what should radiology departments do to prepare? I know everyone is probably already ready, but chest CT should be performed with strict precautions to minimize hazardous exposures. Perform at sites with less traffic if possible to avoid exposure of other patients and staff. Maximize distances between patients in waiting areas. Radiology personnel should use appropriate PPE, including face mask, eye protection, gown, and gloves, right? We need to protect our technologists who help us perform these scans. Deep cleaning of the CT exam room is necessary before imaging the next patient. The CT examination room downtime between cases may be between half an hour to an hour to allow for room decontamination and passive air exchange. Remember, in closed environments, the COVID virus could actually maintain itself in the air for a small period of time. What about CT protocol, right? So we recommend non-contrast enhanced chest CT unless there's a suspicion for PE, thromboembolic disease, in which case pulmonary CTA could be performed. So low-dose chest CT has been shown to have non-inferior diagnostic quality for imaging patients with COVID-19. So remember, as I showed you in some of the cases, some of these patients get recurrent imaging. So we need to be careful with dose. So some studies have reduced dose by up to 90% and still had non-inferior diagnostic ability. So remember, we don't know a lot of the long-term sequelae of COVID-19, so these patients might have to come back with repeated CTs. And lastly, limited reconstructions could be feasible. And one of my institutions where I trained in, their protocol for COVID-19 just involved sending coronal sequences and lung windows to the radiologist to interpret. So they didn't send the axials or sagittals or the different kernels. They just sent a sharp kernel and in coronal, just to get that anterior, posterior, central versus peripheral, apical versus basal distribution noted. So in summary, thanks a lot for your time. At this time, routine screening, especially with CT, is not recommended for COVID. There are hallmark CT features that support the diagnosis of COVID-19. COVID-19 is primarily a respiratory disease, but has systemic effects, and information on COVID-19 is still evolving. So definitely keep reading the literature and try to get the most up-to-date information. Well, thank you so much for having me. This has been a lot of fun.